Hi, everybody. Hi. Welcome. You know what tonight is? It's almost halfway through this year of 2015, and it's also our 23rd program of the year, and we're scheduled for a total of 46 so far this year. 46 programs in 52 weeks. When do we sleep, right? So, anyway, for those that don't know, my name is Stuart Schlossman, and yes, president and founder of this great organization that we call MS Views and News. Why? Because we're giving you views and we're giving you news, and it's mainly the news that we want you to know about. All right, before all this other chatter is going to happen tonight, I ask everybody here, along with me, to thank Teva Neuroscience, because they are the ones that gave us the funding to do tonight's program. So we want to thank you all. I want to thank Teva. You know, we rely on the pharmaceutical dollars to do our programs, and the pharmaceutical industry actually wants you all to learn from these types of programs. Whether it be MS Views and News or another patient advocacy organization, we are the ones that are providing you with information that you need to learn and help you moderate yourselves and your lives with multiple sclerosis. If you're the caregiver, it's great that you're attending these programs as well, because we actually want you to know even more than the patient, because the patient is going to need you to help them possibly down the line. Okay, going a little bit further now. MS Views and News, as I mentioned, there's over 150 videos on the YouTube channel, and that's because since 2010, when we began, we have done over 160 programs in just 5 years. And again, that's a great thing. This year, as I mentioned, we're doing number 23. We're on the path to do 46, possibly a few more. Maybe we'll do 52. That would be rough, huh? Good smiles out there. Tonight's format, for those who haven't seen what's been on the table, it's at the centerpiece. I see one right there. It's never been looked at. You don't want to look at it? You don't want to see what's doing tonight? Okay, there you go. All right, so first speaker is Brian Stango. For those that know, the neurologist. Okay. That's right, it's nice to clap, come on. There you go. All right, next up we have Rhonda Freeman. She's a PhD neuropsychologist, and she's going to speak with you about the benefits of the neuropsychological testing, how it relates to multiple sclerosis, testing, assessment, and other things. You would think I know how to say that word by now. And then we're going to have Jeffrey Siegel, and many people have seen Jeff do his antics and other things that he does to help you stretch out, get rid of some spasticity, help you relieve your bodies of pain that you might be feeling. So Jeff will be up here last. And now I'm going to ask Jennifer Falk, who's our social worker. For those who haven't heard, yes, we have a social worker now. And Jennifer Falk is with us, and she's going to speak to you for a few minutes, and then she'll introduce the speakers again. Thank you.
Great. Thank you, Stuart. Good evening, everyone. Hi. My name's Jennifer Falk, and I'm a social worker. I have my master's degree in social work, and I've chosen to make social work my focus of social work to working solely with the MS community. So I work with MS patients, with their family members, and with everyone that is impacted by living with MS. So MS Views and News is growing, and they recently have set up a 1-800 helpline where I am on the other end. So the paper that I put out in front of you is my contact information. And I get calls every day with people living with MS that are asking questions, that have an issue, something's come up new, they want information, and I'm able to give them that information. So that's serving the state of Florida. So you all are welcome to call me. And you may not have any issues now, but keep my number, because you never know. Sometimes something comes up, a change in insurance, a need for financial assistance, a change in your formulary, many different issues that I can help you with. And you can kind of see that listed down the side of the paper here. So I hope to hear from all of you soon. And we've got a great program lined up today. So
we have a very full schedule tonight, so we're going to get started with our next speaker, Rhonda Freeman. And Rhonda Freeman is a PhD in neuropsychology, and she's got quite a history of doing for the community. And come on up.
Hello, everybody. Thank you for having me here. I want to talk to you today about neuropsychology. How many of you are familiar with neuropsychology at all? Not necessarily had any eval, but maybe just know about it? A few people? Okay. All right, great. Well, I'm going to talk to you about that. But first, let's talk just a little bit about MS. As you know, it's an inflammatory demyelinating condition, and it comes with axonal damage. And at one point, we thought it only impacts the white matter of the brain, the communication. But now we know that it also impacts the gray matter of the brain. And the reason that that's important is because a lot of the gray matter regions are associated with the cognitive decline that we see. And so people have memory problems, concentration problems, articulation problems, and word finding difficulties. And the rate of cognitive problems is actually pretty high in MS. It starts off, we think about it can be 45 to 70% of individuals with MS also have trouble with thinking. Now, the trouble with thinking doesn't go hand in hand with your physical status. So you can have very little lesion load, very, very little physical changes, but actually have very high cognitive difficulties. And so you may look great. You may look like you can function just fine, but you're experiencing trouble with your memory and trouble concentrating and focusing. And so sometimes when someone goes to a doctor and they explain that I'm having a lot of problems, they may look good, but that look does not describe or explain what's going on with them cognitively. So let me just give you three main areas that we're going to touch on today. One, I'm going to give you a little bit of neuropsych basics, and then we're going to talk about what cognitive problems are really common for MS, and then we're going to talk a little bit about what you can do about it. So one of the things I want to do, though, is I'm going to give you a vignette in a little bit, and in that way, you and I can see what it's like for somebody with MS who comes to our office. We'll look at her neuropsych results, and then I want you to help me decide if this person has cognitive problems or not, okay? But that's going to be in a bit. So why would somebody be referred for a neuropsychological evaluation? Well, people are referred for neuropsych when we want to know how the brain is functioning. We want to know how thinking is. We want to know what's going on with their behavior and even what's going on with their mood and sort of a combination of that as well, because no one kind of comes in with only one thing, or very few people come in with just one thing. So for example, if somebody has memory problems, we can do an evaluation and determine if these memory problems are just normal aging, which it could be, or if it's actually a cognitive disorder. And we do that by using different cognitive tests. And so we'll test intellect, language, skills, visual spatial processing, and then we'll look at the scores and determine whether or not there's impairment. So one of the biggest complaints we get with neuropsych is the testing duration. Anybody have any idea about how long they take a neuropsych eval? I hear hours coming. 3 days. Wow, yeah, they can take a long time. The range is about 3 to 6 hours. And my evals, I tend to be in a range of 4 to 5 hours, and I split it up because if somebody's very tired, the last thing you want to do is test somebody who's exhausted. You're not going to get good data, and you're not really testing the cognitive functioning. You're simply seeing somebody who's exhausted, and they want to just get done. So we tend to break it up when there's fatigue. Now, it consists of 3 different sections. It starts off with the interview and history, because I have to get to know you. I have to get to know what's going on in your life. I have to know what your stress status is, if there are any other cognitive difficulties that you've had prior to having MS. And then, of course, there's the testing. And the way that we know if you have difficulties or not is that with the test, we compare you to your age and your education group. So all the tests have been what's called normed. And for example, if somebody's 55, I would look at the scores for other people who are 55 with, let's say, 12 years of education, and you get compared to that group if that is a group that you fall into. That would not be the same norms I would use for somebody who is 20 years old with, let's say, 12 years of education. The norms are just different. The scoring part is what happens when the person is not there. So that's just something that I do on my own in order to get a gauge of where you are. So factors that are really important to take into account with the neuropsych is obviously not only the test results, but is there a mood disorder? So I have to determine, does a person have depression? Are they struggling with anxiety? Do they have other cognitive problems? It's not uncommon that I will see a patient who has ADHD, for example, but then they also have MS. And they want to know, wait, is just simply my ADHD that's kind of acting up because I'm stressed, or is this on top of it the overlay of MS symptoms? We have people who have had a head injury maybe 10 years ago and they were unconscious for an hour and they've had some kind of damage to the brain in that way. And they also want to know, how do we tell if it's MS or if it's my concussion? What's the difference? And so I have to take those variables into account. I take medication into account because there's some medications that you all may take that can cloud the testing. It can kind of dull cognition, like maybe something for anxiety could do that, a painkiller could do that. But then we have medications that do the opposite, that stimulate the brain. For example, medications like vignettes. They can actually, when I give you concentration tests, make those scores a lot higher than what they would really be if you were not taking that medication. Then we look at stress. That's a really big factor because if you have somebody in the office who is under duress and they're going to have a hard time focusing with you. So if, let's say they're told, one more mistake and I got to let you go by their boss, that person is not going to be in a good state when they're sitting in your office trying to take a 5-hour test. So you need to check in to see what's going on with them. And then sleep disorders. There are certain sleep disorders that actually have a direct impact on how the brain works. One of them is obstructive sleep apnea. And that tends to bring along what's called executive function problems. So sometimes people have trouble with organizing and planning when they have that kind of condition. So what areas do we look at with the neuropsych? I always start off with an intelligence test somewhere during the evaluation because the intelligence test, the IQ score, is what kind of anchors things. It lets me know what your range should be. So for example, if I find out through the IQ test that your score is very, very high, then we're expecting all the other areas of cognition to also be very high. It's rare that somebody would have, let's say, a high IQ and then other areas of functioning are very low. Obviously, we look at memory in a neuropsych. We look at attention concentration, and especially with MS, we want to make sure we're looking at divided attention because some people have trouble sort of going from one task to the next and switching back and forth. Like when you have a lot of things going on, you can handle, have a lot of balls in the air. Someone interrupts you and it's hard to get back to it. Well, that's divided attention, so we look at that. The visual spatial, visual constructional skills. We look at working memory. And what that means is it's a very, very short-term type of memory. And so, for example, if I were to give you numbers and I say these numbers forward, I say hold on to these numbers in your mind and then say the numbers back to me backwards. But you will not have written them down. You'll just do it right from your mind. That would be working memory in action. Then we look at language. Can you name things? Is your articulation? All right. And then processing speed, which is a big one for MS because sometimes processing speed tends to get a little bit slower. The brain slows down. So those are the things that we look at in a neuropsych. Really crudely, we categorize neuropsych results in 3 different ways. It's either going to be normal, which is just regular age-associated decline, mild cognitive impairment, or dementia. And mild cognitive impairment, it basically means it's just one area that's problematic. So for example, a person has memory problems, and they're severe though. They're not just a little bit of memory problems, but it's a significant memory problem, but it didn't cross over into the area of dementia. Dementia refers to a set of conditions where there's 2 areas of impairment and there's functional decline. So this person is struggling tremendously. And so one of the things with dementia we need to figure out is why that person has a dementia. And, excuse me, it's not uncommon that somebody with MS will ask me, do I have Alzheimer's disease? Because it might feel that way, that all of a sudden they don't have access to their memory the way that they used to. And so there's a concern of, well, is this MS only, or am I developing dementia like Alzheimer's disease? And so it's unlikely someone with MS, the level of difficulties they had would be at a dementia level. It tends not to be. It tends to be more of a mild cognitive impairment type of difficulty. But we would, of course, do the neuropsych check just to make sure. So let's go through this vignette. So let me play this for you. So this is Mrs. Cog, and she comes to the office and she talks about problems with her memory. She's really worried because she's not thinking the way that she used to. Her focusing is very poor, and she's always tired. And not just physically, but just mentally tired. And this has been really worrying her. And so she decides to come for the neuropsych. She explains, though, that she's a teacher, professor, and she's not doing her work very well. She always feels like she's behind. She's getting complaints from other staff members because she's not really holding her responsibilities. And so she tells her doctor about it, and he orders a neuropsych evaluation. And so let's go over Mrs. Cog's results. So her neuropsych looks like this. She has no history of learning problems or attention deficit disorder in her past and childhood, so we can rule that out as being any issue. She's very fatigued at work. We had to do the evaluation in 2 parts. You check into her emotional status just to make sure that depression or anxiety is not a factor, and for her, it's not. Her IQ was at 119, which is at the 90th percentile, which is very good. It's in the high average range. And then when you look at all her neuropsych scores, they were also in the high average range, so she did really well. When we gave her executive function tests, meaning can she plan, can she reason, can she figure things out, those scores were in the low average range. And then her processing speed score was in the average range. So take a look at that for a moment, because the next question I'm going to ask you is whether or not you think I would diagnose there being a problem. Okay, so just take one look. All right, so your question or your options is A, Mrs. Cog is fine. She's probably stressed and she has a very demanding job as a university professor, so she's fine. Or the other option is B, she's demonstrating cognitive decline, likely in association with MS. So how many say it's A? Okay. And how many say it's B? You think Mrs. Cog is demonstrating difficulties? Okay. And it is actually B. Mrs. Cog is demonstrating difficulties likely associated with MS. Because MS evaluations tend not to look like a dementia evaluation, so even though her score was low average, for somebody with a high average IQ, that's a pretty big decline. And it's also consistent with the symptoms that she reported, that she's having trouble with her thinking, she's having trouble focusing, and pulling out information. All right, so what are the cognitive problems of MS? Cognitive problems can change a person's life. Studies have indicated that cognition tends to be the most significant issue for somebody when they're working, and individuals with cognitive problems tend to be less likely to be working than others with MS. And it can also be the first symptom, so it doesn't necessarily go along with disease duration. So it's not that, okay, after 5 years you start having cognitive problems, or after 10 years, it can actually be the first symptom. So let's look at some of the things that we see with cognition in MS. As we talked about earlier, it can be present regardless of the physical status. Physical status can be absolutely fine, but memory can be poor, concentration can be poor, or processing speed can be poor. And the symptoms tend to be worse for those with primary progressive MS rather than the relapsing remitting MS. And many studies have associated cognitive problems with gray matter changes. So you know with MS, we're often looking at the white matter changes, we're often looking at the lesion load, but in actuality, that's not a good indicator of whether or not a person would have cognitive problems, because cognitive troubles tend to be associated with gray matter changes. So what are some of the cognitive difficulties we see when somebody has MS? there tends to be a decrease in processing speed. So information is just a lot harder to process, and it's harder to think and be as efficient as you were before. A person might feel like they're slower at work, or it takes longer to get things done. They may have memory problems, so it's tough to pull out information that they just saw or pull out information even from the distant past. There can be a decline in attention regulation, so you might need one thing to happen at a time. It's difficult to sort of juggle your attention and delegate it across many different things. Multitasking, for example, tends to decline. There might be problems with executive functions. So somebody who has a job that requires a lot of organization, they might find themselves becoming very disorganized or getting complaints regarding them not finishing the work properly. And then there's visual spatial problems for some. And then working memory we talked about before. And then word finding problems where you feel like the word is right on the tip of your tongue, but it's just not coming out. And that experience happens to everybody, even without cognitive issues. But for some, with this condition, it can happen quite significantly and consistently. So why are there cognitive changes along with MS? So it's essentially basically the degeneration that happens with the condition, as well as the brain efforts to reorganize itself, because the brain's going to try to make some repairs on its own, and sometimes when it does that, it doesn't do it very efficiently, and in doing so, it makes it a lot harder to process information the way that you used to. So the two most common things we see when it comes to cognition in MS is memory problems and information processing speed. That tends to be slow, and memory tends to be weak, if you have cognitive issues at all, because some with MS, as you know, have absolutely no cognitive changes. So let's talk about memory. Memory is handled by a part of the brain called the hippocampus, and that's their little yellow part that you see. And essentially, what happens for some is that area starts to have demyelination and starts to get atrophy. And when it starts to atrophy, we start seeing trouble with memory and pulling out information and also encoding new information. So the kind of memory problems we see with MS, they're twofold. There's two different types. One type is that it takes a lot more repetition to learn the information. You need to hear it a lot more than maybe you used to, maybe 2 or 3 times. The person might experience trouble retrieving information. So if you get a hint, you go, oh, okay, now I know. But at first, it may be a little bit of a search to pull out the information that you need, pulling out the word that you need. And also, we found some difficulties with what's called prospective memory. And that's, for example, if I had an appointment, let's say at 7 o'clock on Friday, upcoming, prospective memory is remembering to remember that you had that appointment. So if it wasn't written down, or if I got an alert on my phone, I might forget. And that's a type of memory that we also see as being problematic for some with MS. Sex seems to matter. Cognitive problems can be worse for males who have evidence of atrophy in the gray matter part of the brain, not the white matter I talked about, but the gray matter. And so let's talk about the thalamus. The thalamus is important because it's the part of the brain that's considered the relay station. And it's like the central hub. So it takes in all of our sensory information, well, most sensory information. It doesn't take in the smell. And so what happens with the thalamus is that when there's atrophy in this area, we see quite a lot of cognitive changes. For some, it could be significant cognitive changes. So processing speed tends to plummet and go down, and people tend to have trouble with remembering. When someone has thalamic involvement, there tends to be a greater amount of cognitive changes. And so, one second. And we can tell the status of the thalamus because when you look on MRI, the third ventricle of the brain, that area tends to be a bit wider. And so that's how your neurologist can know if your thalamus happens to be involved. And so is there protection from decline? And what do you think? Can you kind of be protected from getting this type of difficulty or having this kind of difficulty, do you think, perhaps? I hear a little bit of yes, a little bit no, okay. Yeah, actually, we can. We have what's called cognitive reserve. And what that means is basically people who have like more enrichment from an intellectual standpoint, like maybe higher levels of education or more demanding jobs where they're using their brain, or they've had many different experiences that allowed their brain throughout their lifetime to make many different kinds of neurological and neuronal connections. They have a bigger reserve than someone who has very minimal levels of education who didn't really enrich their brain. Their brain and can take, let's say, the same amount of insult from MS compared to the person with the lower and understand it a little bit more. So it's what you bring to the table as your starting point. And for those who have the higher amounts of education and intellectual enrichment, they tend to do better. However, you can change this for those who may not have that same strong level of cognitive reserve, and it's called reserve building. And that just means that you go out, you get experiences, and you expose your brain to different things, such as learning a language or improving on a hobby that you really enjoy. You can actually make the brain stronger. So what can we do when we have cognitive deficits? Well, there's 3 things that you can do. One is called cognitive stimulation, and so that basically refers to like cognitive rehabilitation. So that'll be done by like a speech therapist or a neuropsychologist. The other is what I just talked about, which is just overall enrichment. That is not stimulation where you're doing like one type of task, like memory test or memory tasks, but rather just enrichment overall. You're enjoying yourself and exposing yourself to different experiences. And then there's compensatory approach, and that means that you don't work out the brain at all, but you just use different types of strategies. So you write things down or you use an alert on your phone, but you don't actually work out the brain to change it. So when it comes to cognitive rehabilitation, what are we doing? We're basically just building new connections in the brain. And you're trying to strengthen current pathways, but also make new pathways, because the brain can actually work around when there's problem. You guys remember Gabby Gifford from a few years ago? She was a congresswoman who was shot in the left side of the head. Well, she actually was given cognitive rehabilitation to help her with her speech. So for example, her therapist would say to her, repeat a word. And she tried really hard to repeat this word, but she just couldn't do it. It was just one simple word. When the therapist decided, let's do it this way, let's sing the word. And she sung the word into a song and rhythmically sort of tapped out the word. The next instant, Gabby could sing. She could sing, but she couldn't speak. And that's because the brain went around the area that was having trouble, and it used the right side of the brain to actually access speech. And so the brain's capable of working around, but you have to sort of give it that experience. You have to have somebody who can show you how to do it. And then obviously the compensatory strategies is what we discussed. So if you go to a cognitive therapist, they're going to do both with you if it's needed. And then the last thing is that you have to move your body. That's almost as important as the cognitive stimulation activities, because research has shown that it's pretty much equivalent as far as benefit to the brain. All right, so you guys have any questions about neuropsych or cognition or thinking or memory? Yeah? Mm-hmm.
Mathematical aspects of full recovery versus 50%, 90%. I mean, how many people out of 10 will be able to recover fully, and how many will have residual problems?
From a concussion?
Yeah.
Yeah, it depends on a lot of variables. One, the type of injury. So when we rate this as mild, moderate, severe. So if it was just really mild, then it tends not to leave significant cognitive difficulties. So it can be a lot of recovery, but then there are other variables like age, and then like education, and what kind of difficulties were you having in the first place? Was it memory? Was it concentration? So a lot of variables come into play with that. So I can't give you a percentage because it's really individual.
Any other questions?
We're trying to hold the questions until she's finished, yes?
Actually, I did.
I think she's finished.
Oh, you finished already? Okay, you ready? Who's got questions?
Oh, I got a
Already
question.
got to start all the way over there. Shoot, get.
Hello. Hi. My question is, there's so much written about brain health as it pertains to the gut. A lot of research has taken place with the microbiome, and Dr. Perlmutter wrote a great book. What is your opinion concerning your current knowledge, and just overall, do you think it has merits in improving cognition or preventing brain degeneration, not only in MS, but in any as we age?
Well, I don't know a lot of the literature regarding the gut and cognition, so I can't answer that specifically. But obviously, diet is extremely important in giving the brain what it needs from a nutritional standpoint, so that it functions optimally. But as far as the gut, I don't have specifics on that research.
Any other questions?
Hi. I used to be the top salesman in my company. I went down to the bottom, and then finally they let me go because they liked me. So they kept me for a long, long time. But also I'm trying to exercise more. I can't really walk that good, but a lot of times I can't retrieve words in my head. So is that mild cognition, or is it just normal?
Well, it depends on how much it happens. And I mean, that could be one of the symptoms for you, but I wouldn't know until, I would have an opportunity to evaluate and see where you fell and how you range in comparison to testing norms. Yeah.
Okay, thank you.
Question over here.
Are there any medications that can improve cognition?
Yeah, there are medications that can improve cognition. For MS specifically, though, there are no medications. There are medications for other conditions. For example, there's medication for Alzheimer's disease, and they actually tried that medicine with MS, and it wasn't all that effective. There are obviously the stimulants that can help quite a lot with attention and concentration. But as far as the specific medicines, there's nothing on the market right now for cognition.
You said stimulants?
Yeah, stimulants, medications like Vyvanse, Concerta, the medicines that fall under the ADHD category, they can actually be helpful.
Which ones were they?
Vyvanse is, I'm just giving sort of for examples. So Vyvanse is one of them. Thank you.
Are you still doing a question over there?
How do we get to see you? Do you need a prescription?
Yes, typically it's from the neurologist because neuropsychs have to be medically necessary. So for example, Steingo and I work in the same office. So what he would do is write a prescription for it and say that we need to evaluate what's going on cognitively. And so I would be the one who'd see you, yeah.
Generally covered by insurance?
Yes, generally covered by insurance.
Oh, that's it. Next.
I have a question about memory. I see a lot of ads on TV for a new pill that you can get at CVS or Walgreens, and you're supposed to increase your memory. Do you think that you can take a pill and improve your memory? I want to say Proventus, which is something like that.
I know what you're talking about, that supplement. We don't use those. We obviously use the real, FDA approved medications at our office. Can someone take a supplement? Yes. Could it possibly make them feel a little bit better? It could, but it's not been studied from an FDA standpoint.
Can you talk about cognitive therapy and what it entails and whether or not it's available down here?
So you mean like cognitive training where you're going? Yeah, okay. Yeah, it is available down here. And it has to be at a specialty site where they have either a neuropsychologist or a speech therapist doing it. And basically they put you through different kinds of exercises. Sometimes it's computer exercises, and they have you work out different sections of the brain, but while they're also teaching you the why behind it. And they're also teaching you how to compensate and how to engage different regions of the brain, just in case the part that you're trying to work on is too damaged or struggling too much. So yes, we definitely do have that available down here.
Do you recommend any word games or whatnot for people to use to keep their memory intact, like Sudoku or whatever it's called, and crosswords and?
I would recommend that you go deeper than that, because those things they may not be quite enough for making new connections within the brain. So it's better when you're doing something that involves a lot of different areas of cognition, not just maybe one thing like pulling out a word, but that involves a lot of different skills. So learning a new language is difficult, and it has to be difficult enough for the brain to make new connections. Something where you have to socialize with somebody, but just crosswords alone is probably not enough.
Do you look at somebody's MRI to help give you an indication of where the cognitive problem could be?
Neurologists can do that. I tend not to go in that direction because I'm lucky enough to work in a group with about 20 neurologists, and so that's in their area. And so they can look at your MRI, for example, and tell where the problems are, and they talk to you about it. And I look at the report in their report, and I also reinforce it. Okay, this is what's going on. I just kind of add the cognitive component to it.
Right, so
Yeah.
you do take that into consideration if it's in that report.
Absolutely, yeah.
My question is, do you have any, or do you recommend any apps that people can use on their computer or phone that, even if they don't have or have been diagnosed with cognitive issues that might help?
Yeah, things like Lumosity. I don't know if Lumosity has an app, but they have a lot of different very stimulating cognitive games that you can play. I'm not sure if it's Lumosity or another company that when you do the game, they continue to increase the complexity of the task, which is really what you need, because you don't want a task that you can just nail and get it like that, because that's just entertaining yourself. You want it challenging so you feel a little bit uncomfortable with it. And you want to think, my gosh, I can't quite get this. That's when you are helping the brain advance, but not when you're just getting it very easily. You're just kind of entertaining yourself.
I have a question.
Oh, yeah.
What's your opinion on brain stimulation and, say, introduction to music therapy or dance therapy or any type, something new or art that a person might have never tried before?
I think that's wonderful, especially I love dance. But that's absolutely wonderful because it engages other parts of the brain. And that's, for example, how they help Gabby Gifford. They decided not to just kind of focus on the speech part of it, where they just kept drilling speech games with her. And they decided, let's bring in a music therapist. And they played music, and they had her actually start singing, and that was what helped her recover. So, and yeah, the arts are absolutely helpful. Yeah.
Well, thank you, Dr. Freeman. So again, if you need to contact Dr. Freeman, she's with Sunrise Medical Group out of the Hollywood office in Hollywood, right? So you could just contact her there, I guess, and or speak with your neurologist first and try to get an appointment to see her.